Great. Thrilled to speak with you guys today. And I'm especially thrilled because Dean Siddig has been a mentor of mine for the last couple of years. One of the things that I'm lucky enough to have is, in addition to my appointment at MD Anderson, I'm also joint appointed at OHSU in their radiation oncology department, which is incredibly tightly integrated with Bill Hirsch's group at DMICE. So I've been fortunate through those interactions to have some interactions. And in addition to being a clinical radiation oncologist, I'm board certified in radiation oncology. I have a PhD, as was mentioned, in radiological sciences, which is imaging physics, is my expertise there. But I'm also a board certified clinical informatician. Now, I'm not an informatics specialist the way you guys are. So the goal of this talk today is really to give you a 30,000-foot view of radiation oncology. Our field has some unique features with regard to informatics utilization and workflow that I think might be interesting to y'all as a group. And so because of that, as we go through, if there's questions, feel free to stop me and we can camp out in a specific area of interest. So I have a ton of slides. I don't have any aspirations. I need to get through all of them. If there's something that's more interesting to us as a group, we can stop and examine that. I'm fortunate enough to be funded by some very generous funders. And I'm fortunate enough to be part of what is hands down the best clinical radiation oncology head and neck group in the United States. We're part of what is widely recognized as the world's best head and neck cancer team, where multidisciplinary focus really comes into play. I'm part of a larger institutional support infrastructure that enables all of the research and clinical activities I do with enormous amounts of support. And I'm incredibly thankful to all of them. I'm especially thankful as well, let me see if I can close this. Well, you can see that people can see me. I'm incredibly thankful that I also have literally decades of personal mentorship. And you may recognize Dean, but also Jayshree Kalpathy Kramer, who's been a long-term collaborator of mine now for almost 9 years, is also a world-class informatician. And so they're really the ones who professionally have helped guide me as I've begun this interface within the informatics space. Let's see if that's working now. Maybe not. Uh-oh. There we go. I'm also fortunate enough to work with a huge team of trainees who are exceptionally gifted and bright and really make this interaction very fun. And I'm very thankful to be part of a very supportive family. For those of us who treat cancer, it becomes very clear that every cancer treatment is a personal mission for someone as they and their family struggle with this. So to have the support of your family is something I think is very important. At a personal level, my focus is on developing the infrastructure for advanced image-guided clinical radiotherapy trials. And we'll kind of talk about what that means, but that's really what I'm about. When you think about radiation therapy, if you think of who cures cancer, the vast majority of cancers are still cured by surgery, right? Still fundamentally, cutting tumors out is the primary way that we cure these. But a lower number are going to get primary radiation, which cures their therapy. Now, 2/3 of patients will get radiation therapy at some time during their lifetime, but of those patients, a smaller percentage are actually cured by radiation. So we often use it palliatively. Yes, ma'am.
So then is radiation at all times ineffective or partly effective?
Well, it's more that it's always effective at killing cells. It's not uniformly effective at killing all kinds of cells in all situations. But when we think about curative intent radiotherapy, it's routinely used. Oddly enough, a large fraction of the radiation we use is actually palliative. So it's designed in situations where we don't believe that we're going to be able to cure the patient, but we can maintain function or prolong life without suffering for an extended period of time. So this is really, if you think about it in terms of curative intent, the answer is it doesn't cure all cancers, right? But it's very field specific. Chemotherapy cures by itself a surprisingly low number of patients. It's fairly ineffective as a single therapy. Now, in combination, these are used with greater frequency. Radiation oncology as a field is actually an interface between 3 different subfields. So there is a separate field of radiation oncology physics because of the physics of how we deliver the therapy. There is a field of radiation biology, which is the basic science of human interactions with radiation. And then finally, there's clinical oncology, which is the component that I sit There's a lot of overlap in our field between informatics because one of our gurus in radiation oncology is the late, great Ira Kaled. Many of you guys may have read his book when you were students. I know I did. It was very Lisp-based. But Ira actually developed the early treatment planning systems that we use for radiation therapy. And many of the concepts that are integrated in our field were developed alongside the simultaneous development of biomedical informatics as a field where Ira was also a player. So you may see a lot of overlap. When we think about radiation therapy, it really comprises a number of different delivery techniques. So the one we're going to talk most about today is what's called external beam radiation, where we use X-rays that are very high energy which pass through the patient. But there's other techniques where we insert radioactive materials inside the patient. That's called brachytherapy. And there's techniques where we use high dose through limited number of beams. That's called stereotactic radiation. And then there's particle therapy where we use exotic protons. So if you go across Burtner and Old Spanish Trail, there's a $160 million proton facility that we use. I'm not going to spend a lot of time camping out on that, but it's kind of interesting. Radiation therapy was initiated very, very early after the discovery of X-rays. So you have, William Conrad Röntgen, 1895, he discovers X-rays, he takes a picture of his wife's hand, and we're off to the races. Within 2 years, it became apparent that cells that were dividing were sensitive to radiation. And so the application of radiation to dividing cells to try and prevent cancer became hot on the heels of the discovery. The discovery of radioactive materials allowed the implantation of these radioactive substances. And then within a very short interval, this is only 10 years, you could already get to treatments with implanted devices. Within a very short period of time, less than 30 years, we were already doing more complex treatments. And then in the 50s, we began to develop the technical and hardware infrastructure to deliver something that approximates our modern concept of radiation therapy. The first devices that were used to treat radiotherapy basically treated really big fields. You just treated a big box. You just turned on the beam was on or off. It was very binary. And you could treat to very limited doses, and it was really unwieldy. Over time, mechanical improvements allowed us to shape the radiation doses, but what really has been the driver of my field has been the increase in computing power. The physical mechanics of radiation beams have not changed appreciably since 1895. And the materials we use to block them are just metal. But what has changed is our ability to model complex radiation delivery and spatial delivery in ways that are computationally effective. So our ability to deliver radiation plans actually follows Moore's law, which is kind of cool. So now we're able to do these kind of more elaborate techniques, which we'll talk about broadly in a second, where we can shape the radiation dose to fit where the tumor is in space, and where we can integrate imaging information. Very simply, radiation interacts with matter by knocking electrons off of nuclei. And those nuclei, if the electrons are close enough, they will damage DNA that's sitting nearby. So the fundamental primary driver of all radiation is hitting DNA and causing DNA damage. Now, what happens though is normal cells know how to stop if they're hit by radiation, their DNA is damaged. But abnormal cells, because they're cycling all the time, they keep dividing even if the DNA is damaged. And this leads to catastrophic failure of the cell. The cell just can't keep up. It can't continue to accumulate damage without repairing it. So what we're really playing on is this difference between how well normal tissue can repair radiation and how well dividing cells or tumors can deal with radiation. But we have a problem, because at the end of the day, all normal tissue is dividing too, at various rates. So very fast dividing normal tissue, like the skin, is exquisitely sensitive to radiation. And late dividing tissues also have radiation effects, they just play out over a much longer time period. So the amount of radiation dose that we can give to a tumor is not limited by the tumor, it's limited by the normal tissue that surrounds it. So I can kill any tumor if given a high enough radiation dose. The problem is the patient's often attached to it. For this reason, we've got to always think about the difference between not only our ability to create a toxic effect on the tumor but also the treatment or the therapeutic effect on the tumor, the chances of killing the tumor. So this is tumor killing or patient cure, but also the fact that there is a risk of toxic effects to the patient. And this small window varies a lot by different structures in the body, by different locations of where the organs are and where the tumor is located. So some tumors are more sensitive, and if that's the case, well, your therapeutic window may be easier because the dose required to kill them is quite low. But if it takes a very high radiation dose, the probability of intersecting with a toxic effect goes up. So this is something we continually balance in our heads. Now, in the old days, this was really hard because you had to cover a really large field of technique. And basically, the old cobalt machines just had a piece of cobalt and a little sliding window. And you can see the gentleman here adjusting it. So you'd make an adjustment, you'd step out of the room, you'd press a button, the little sliding window would open, and radiation would come out. Very simple mechanical devices. Now we have these complex computer-controlled machines with sub-millimeter leaves which can open and close dynamically as the machine rotates around the patient in real time. So these are incredibly complex technical devices. And again, the physics of pushing radiation through an opening still stay the same, but what has changed is our ability to know when to open the beams, when to keep them open and when to keep them closed. And there's a host of different brand names of different devices. We have all of them. And we even do some neat stuff where we spent gazillions of dollars building proton machines to try and enhance these physical properties. But the real evolution has been in improved imaging and improved ability to know where the tumor is and then shape our dose to it. So again, in the old days, we just had an open field and we used X-rays to align things. We then moved to a technique where we could see things with 3D CT imaging or MRI imaging. So now we had a three-dimensional model of the patient, and then we've taken that information and moved to more elaborate techniques. On the clinical side for radiation oncology, basically what happens is we start with a decision about whether the patient will receive radiation. Oftentimes the patient may get surgery first. So for example, as was alluded, sometimes the tumor is so big you can't cure it with radiation without harming the patient. In those cases, we'll often do surgery, remove as much of the tumor as we can, and treat the remaining cells with radiation therapy. In some cases, we'll use chemotherapy to make the cells more sensitive to radiation. So those therapeutic decisions are made in combination. We then have a series of treatment preparation, which we'll talk about in a little bit more detail, where we then simulate the patient. The simulation is really like a CT scan or a MRI, but the patient is in an immobilization device. And so by doing that, we have a rigid three-dimensional model to which we can then do all of our later calculations and all of our later modeling of the patient's expected outcomes. We then do radiation planning, which involves the physics process we'll talk about in a bit. And finally, we move on to treatment and evaluation. After all that's all done, then we follow the patient and evaluate whether the treatment was effective. So at a certain level, fundamentally, what this represents is this interaction that you guys are quite familiar with, where you talk about the individuals who are operating these operator-dependent processes, but then also the information and software-mediated interactions that lead to our utilization of the hardware. So the radiation delivery processes are indirectly software-mediated in almost every case. I do not interact directly with radiation machines ever. I don't physically handle them. Every interaction I have with them is through software. So again, this is a kind of workflow that shows this as treatment options. Patients are referred to the radiation oncologist. Information is put in the hospital system. Treatment options are discussed. A technique, again, we're focusing on an external beam. And then finally, treatment planning and delivery occur. It's a lot more complex than this. So all of these steps are very, very industrialized, high throughput processes. So to put this in perspective, MD Anderson's head and neck group, my team, treats about 1,000 head and neck cancer patients a year. That is about a third of the number of head and neck cancers that occur in the state of Texas. So we treat a huge number of patients. And so efficiencies and scalability are very, very key. And at each choke point in the process, this is actually, again, a very simplistic overview of what these processes look like. We're iteratively trying to do QA and QI in a way that we can improve not only our efficiency and workflow, but also our accuracy and delivery. because at any point in the information chain, if you make a mistake, the downstream effects are deleterious to the patient. So for example, if you have a consultation with a radiation oncologist and you mess up when you're acquiring your planning CT, the patient's moving, well then every delivery you do based on that planning CT will miss the tumor and the patient will die. So it's bad, it's really bad. So likewise, if you have an error in your computer code while you're planning the radiation treatment in terms of the dose calculation, which has happened. Historically, we actually found out, we did a study a few years ago, we found that one of the treatment planning systems introduced in the early 2000s was off on the dose calculations by 20%. So there were 2 years worth of patients nationally who died because of failure to QA a software bug, right? So these have real-time implications for real patients, and the processes cannot be divorced from that without some degree of risk. What makes radiation oncology, again, fundamentally different is our utilization of images is so heavy. So the treatments we're delivering are also not like regular treatments. So if you give chemotherapy, the patient gets chemotherapy. If you give an antibiotic, the patient gets an antibiotic. And there may be a dose component to that. The patient gets an antibiotic of dose X, right? The interesting thing about radiation is superimposed upon that is a spatial component. The patient gets X amount of radiation to X region of the patient. The spatial information also has to be encoded and also has to be thought of. And not only that, because the spatial information is reflective of what's going on in the anatomy, treating a patient's head and neck is very different than treating a patient's leg. The side effect profile of treating prostate cancer is radically different than breast cancer, which is radically different than brain cancer. So it's much more complex, and that's why we spend 5 years studying it. This is mediated through a NEMA standardized imaging format called DICOM. DICOM is the standard. How many people here are familiar with DICOM? It should be everybody on the planet. So DICOM is the standard system for diagnostic imaging computer, I forget what the O and M are, but essentially it is the file format standard for any imaging system. And it consists of a map of intensities at a 512 by 512 matrix with iterative slices. And those intensity values are then projected, and that's what you see as a CT scan. So a CT scan is represented by intensity maps on a grayscale grid, 512 by 512, and all imaging that's acquired, ultrasound or MRI or PET or CT imaging or X-ray that you get is digitally a DICOM file. So because we're using images so frequently, DICOM is our lingua franca. It is our standard language system. And it's ubiquitous across all of our processes. So from the very first acquisition of CT images so we can plan the patient in DICOM files, to when we're deciding how we're going to treat the patient, the DICOM information is coded and follows the patient to generate a patient record. This is a little different than in radiation oncology than what you see in radiology. So in radiology, the images are displayed and they're often annotated with information that identifies individual components of the image. So this is a region you need to look out for. In radiation therapy, the data is not just used for diagnosis. It's not just, is there a tumor there, is there not a tumor there? We also have to take that spatial information and identify and say, these subregions of the image represent tumor, these subregions of the image represent a normal tissue you don't want to radiate. And then we use that information to perform our radiation treatment planning. So the same information that's used for diagnosis is used for radiation planning with some modifications. So we spend an enormous amount of time perseverating over these images. The DICOM image objects versus the radiation oncology objects represent this phenomenologically. So when we think about these radiation oncology objects, we also have things like dose information that we can superimpose. And we'll show you kind of what that looks like. So a DICOM image is designed in such a way that you have a study. There's the actual image file. These are those pixel intensities that are laid out as a grid. And then there's a superimposition of another intensity grid that represents the radiation dose that is planned or will be delivered to the patient. So you know not only what the image looks like, but also what the radiation dose to that area is going to look like spatially. We then identify and segment individual subregions using masks so we can identify where organs are. Now, of course, on an image, an organ is not really an organ. My kidney is not the same thing as the picture of my kidney. But the computer will only recognize those subregions of the image file as a kidney if I, as a user, tell it exactly which pixels are kidney. So we have to go in and name them through a process we call segmentation or target delineation. All of the information about how the radiation dose is delivered is included in a portion called the RT plan, which tells you the machine that does the delivery, it tells you the type of beams that were used, it tells you where the beams came from, it tells you how much radiation came through each opening. And then finally, the RT record tells you how many of those treatments were delivered. From an architecture perspective, it's very similar to almost all standardized imaging formats. So it's a fairly straightforward conceptually, but it's key to everything that we do. And so again, you can see that this portion, RT images, is really the only component that's used in most cases by diagnostic imagers with any high frequency. All of the rest of these RT objects, all the rest of these objects within the file structure are representative of different processes in radiation oncology imaging that we interact with. Now, why does this matter? Because the inputs to what I tell the computer on the image file where the tumor is are what the computer then uses to optimize the radiation treatment. So if I tell the computer, this is the tumor right here, I want radiation dose to that area. In the old days, I would just pick a very simple beam arrangement and I would push the button and calculate the dose. And it was pretty simple. But the problem is I might radiate through lots of different normal tissue and I might have a suboptimal radiation plan. So what we end up doing is using computer optimization to arrive at the best possible plan given a series of constraints. In order to get those constraints, I have to give an input to the computer and say, where in space is the tumor, where's the normal structures? Now, I'll tell you, this is not as straightforward as you'd think, because again, we're actually just now, 20 years after developing these technologies, developing good ontologies for how we're going to name these structures. So I'm actually part of a group that's standardizing nationally our nomenclature for individual organs, because as you can imagine, there's like a gazillion different ways that you can describe organs in the body. Do you call something the glottis, or do you call something the larynx? Do you call something the anterior commissure of the larynx? If you just call it anterior commissure, there's a problem because you've got an anterior commissure in your brain and you've got an anterior commissure of your vulva. So anterior commissure is not specific enough. So we have to go through all of these processes as we move the ball forward. Where this matters is different radiation oncologists will often give the information differently to the machine. So this is a study we did where we asked a bunch of radiation oncologists to segment on the DICOM file where the tumor is and the areas they wanted to treat. So on the tumor, which is red, they actually agreed pretty well. But when they looked at the areas they wanted to treat with elective radiation dose, the lymph node levels, they were just all over the place. So what this tells you is there's a huge amount of operator dependence. How I draw on these DICOM files makes a huge difference on how your patient or your family member's radiation plan will be delivered. And so in this respect, radiation therapy is as operator dependent, if not more, than surgery. So people go to the radiation oncologist and they think, I can get radiation treatment at Bob's house of x-rays just as easily as I can get it at a high quality academic center. And the answer is, you really can't. When we look at this variation, it gets even bigger if you have variable clinical information. So if you give the patient chemotherapy first, the agreement between operators drops precipitously. And so this is a really big quality assurance problem. And in most cases, the magnitude of the radiation delivery error is more importantly driven by the information inputs by the operator than it is by the actual physical delivery system. So it's not our machines that are our rate limiting step, it's the human users that are working on these things. For example, we've done some studies where we've looked at how long it takes folks to do these target delineation steps. It's very time intensive. For experienced users, it takes me somewhere between, it says 1 to 2 hours. That's for radiation oncology cases broadly. In a complex scenario like head and neck, it routinely can take me up to 4 hours to contour a head and neck case. Again, it's very low reproducibility. But it's important because if you've got a tumor and it's next to something you don't want to radiate, and you miss, the patient dies, and you've given them side effects. So that's really bad. We call this a geometric miss. It's just the worst possible scenario. So what we do now, currently, is we add a safety margin. We have the tumor volume, and we say, okay, we know there's an organ at risk, but we're going to make sure we don't miss the tumor. So as long as we're not missing tumor, even though the patient may have side effects, at least we didn't let the patient die because we missed it. What we'd really like to do is get better information in such a way that we could identify where the tumor volumes were more effectively, drop that operator dependence, and then have a scenario where we can very, very tightly cover the tumor volume and spare as much of the normal tissue as at all possible. This is really the dream of radiation oncologists. We wake up in the morning thinking how we can just hit tumor and not hit normal tissue effectively. The next part of the process is we feed those inputs into a computer system, which then finds the optimum number of beam arrangements through, and again, I don't know if you got how into optimization you guys are, but we use multi-objective optimization. So we say, I want the tumor to get X amount of radiation. I want this normal structure next to it to get no more than Y amount of radiation. Give me the beam arrangement that does that. Well, that's easy if you only have 2 constraints. But if you have, as we do in the head and neck routinely, 15, 20, 30 different organs at risk, that becomes something that you can't do in your head. So these complex computer problems, we use Monte Carlo simulation for this. So we can do large-scale resampling-based methods and really come up with what we think is the best possible plan given that number of iterations and given those constraints that you gave the computer. So what I end up doing is we feed this information to the computer. It runs thousands and thousands of iterations. You look at the plan and you say, okay, if that plan's not good enough, I have to adjust my constraints. I have to adjust my directives. I have to adjust what I contoured as the areas I want to treat if I want to get a better plan. And this is done, there's a whole field of radiation oncology optimization that really gets into this. What's really impressive is these kinds of processes happen iteratively. So during the course of treatment, as the patient's tumor changes, we might take them back and restart this process, including the prior information. And so it leads to these very complex workflows that, again, are iteratively optimizing to try and get the best possible plan we can at that moment for the patients. This requires a huge computing infrastructure because this information, and I'll be honest with you, it's very interesting because in the vast majority of cases, we just moved to Epic. Nowhere is this information actually involved in the direct EMR. It sits in its own little box inside. So radiation oncology at MD Anderson has its own IT and IS infrastructure that exists totally apart from vendor-supplied EHRs. For this reason, it's a very niche field, which creates a problem because people who have informatics expertise primarily have informatics expertise nowadays in bulk because of the industry needs. And so there's a lot of people who have expertise in NLP or EMR-related functions, and very few who actually have DICOM-specific knowledge bases. So this makes it very difficult because this entire infrastructure that we have here is veiled because it's a relatively small component of the total healthcare field. We do a bunch of QA, and then every day we acquire new images. So every day I look at my patient's images to make sure they're lined up in the same place and that nothing has changed sufficient that I need to start the whole process over again iteratively as they go through treatment. So again, each of those steps has quality assurance processes, and actually we're very effective. So the vast majority of patients I treat, I can align their treatments within 1.5 millimeters every day for a 33-day treatment. So it's an incredible degree of mechanical and physical precision applied at a large scale in order to make sure we don't kill or harm patients on a daily basis. So every day I look at a screen like this and make sure that the image I see on today's visit for the patient aligns with the previous initial treatment. If they need to be replanned, again, we have these iterative processes that take that information from today's plan and feed it back into the loop, and we start the process again. Now in head and neck, this has a real relevance clinically. I don't know if you guys are familiar, but in head and neck cancer, there's an epidemic. There's literally an explosion of head and neck cancer in the United States. And what we thought was when people stopped smoking, that radiation oncologists my age would have no head and neck cancer patients to treat. Because for years and years and years, smoking was the major cause of cancer for head and neck patients. But what we've seen recently is an explosion in human papillomavirus-associated cancers. So folks who had orogenital contact in their youth now are having virally associated cancers. The interesting thing for us in radiation oncology is these human papillomavirus cancers, which are so much more prevalent, are actually much more curable with radiation. The patients are far less likely to die. So patients who have these HPV negative smoker-drinker cancers, they perform like classic head and neck cancers where we'd expect the majority of patients at 5 years would be dead. So we were incredibly aggressive about treatment because we didn't really care about the side effects. If we could just keep you alive, we were just happy. When we saw patients at 5-year visits, we just like high-fived. The shift has been now we have patients who in some cases can have 90% probability of 5 and probably 85% probability of 10-year survival. So these patients, instead of high-fiving when we see them at 5 years, we're saddened because they have more side effects than we'd want to see in someone who's going to survive decades. So the clinical picture matters a lot. I'll skip these because it's kind of a little... Again, the problem is in the head and neck, which is what I treat, there's normal tissue everywhere. There's really not a place that you want to get a tumor that I can shoot a radiation beam without passing through something that's important to you for eating, swallowing, cognition. All of these areas are very important real estate. So as you can imagine, in the old days, when we just blasted one big open beam through the side of your head, we caught everything. Everything in the middle of this space got an equivalent radiation dose. So all of these normal tissues, such as the salivary glands, which are really sensitive to radiation, got high radiation dose. So head and neck cancer patients historically had crippling quality of life because their mouths were so dry they couldn't talk or swallow without a sip of water every time. And it was just terrible. These patients really, really suffered. And it was just really unpleasant. Head and neck cancer was the place you didn't want to work because the patients had so many side effects if they lived 5 years. Well, we were addressing this primary side effect, even though there were a lot of other side effects that we'll talk about in a moment. Dry mouth or xerostomia was the big driver. Now, we figured out that you could plot the relative dose that you gave the parotid gland and the chances of having a salivary flow problem. So if you got this amount of radiation, let's say you got 40 gray, you had about a 50% chance of having reduction in salivary flow. So we knew how much radiation dose we could get away with, like what the tolerance levels were. So once we had the computational and physical ability to model and shape the dose, we began pushing dose away from these parotid glands. We wanted to spare our patients. We said, we want to cover the tumor and cure the patients as well as we ever did, but we want to spare these normal tissues. And we were really, really effective at it. And we did this by using, again, this technique where we let the computer pick all of the different angles and all of the different energies for all of the different angles to give us the best possible plan. So this is a very computationally intensive plan. This is the kind of old thing we could do in our heads in the late 90s. Now the problem is, as you can see, in this plan, the radiation dose is very high. It's only through 2 beams, but everything outside those beams gets no dose. So things were very binary. You either got radiation to an area or you didn't. Now we have that dose spread out over a huge area. And so we started to see side effects we'd never seen before. Problems with irritation at the front of the mouth, which had never really been a problem when we treated the back of the throat. Loss of hair in the back, which is kind of scary because the hair is the first thing that gets passed through, but the brain is right underneath this. And while some of these things would recover, we started to think about it. We realized that the doses to things like your brain stem or the cochlea involved in hearing were actually much higher with our new techniques than they had been with our old techniques. We were doing a better job of sparing one thing, but at the cost of something different. And so we've actually looked into this. One of our group was actually looking at which parts of the brain stem are the cause of nausea and emesis in radiation therapy. Because before the 90s, no one had vomiting with radiation alone. Chemo made you throw up, but radiation didn't. Suddenly, we started having patients who got radiation therapy for head and neck cancer who were vomiting all the time. Well, the reason was we were pushing small amounts of radiation dose through their brainstem that had never gone through there before. So this led us to actually develop, we then said, okay, let's look at the dose and the amount of volume that's receiving it for all these tiny little organs in the brainstem. Can we then identify constraints that we can use in our next optimization routine to try and drive those doses down? So this is what we do iteratively, is we're taking in new data, taking in new spatial information. You have to know first, where is the organ at risk? The reason we'd never identified where these structures were relative to dose because we had no data on it. We weren't looking for it. So it took us a year to figure out exactly how we were going to segment these image files for these tiny little organs and reproducibly do it in a way that we could get this data at scale. And now this is something that's integrated into our clinic every day. So we take the information we got, we take these outputs, and we feed them into the next iteration to get better plans sequentially. This has led to an integration of multimodality imaging in our field. So in our field, we're constantly thinking about how we can standardize the images we get to get better images, make better patient-specific estimations, and then determine how much these extra imaging techniques are going to help in our targeting. This transition is really also reflected in a move from just anatomic volumes, where is the brainstem, to looking at structures that move, like where is the lung, which is moving in real time while you're treating. And then finally, we're now transitioning to functional or biologic volumes. Now, this imaging shift has led us to a paradigm shift, because now we're starting that we can see with better imaging techniques what's going on within the body. We can identify things we couldn't even identify as potential opportunities or problems before. So again, in the old days, we just treated a big box. Now we have these kind of sub-regions that we can treat to different doses, and eventually we're getting better and better at this. But even so, right now, we still treat tumor as if it's one thing. We still treat the tumor volume as if this is tumor and this is your normal kidney, which is next to it. But what we know, in fact, is what's happening inside the tumor is very complex. That there's sub-areas of the tumor that are more deprived of oxygen or hypoxic, that there are areas where there is more tumor burden, there's literally denser tumor cells, that there's areas where there's faster growth, and that these reflect different phenomenon that are happening in the tumor. So the tumor is not a uniform structure either, it's a complex organizational system and microenvironment. But we've never really had the ability to image that, so we never had the ability to modify it. So back in 2000, we started thinking about this idea of the biological target volume. Now, we've gotten really good at being able to physically deliver the dose, but it's only recently that we're still making these inroads in biologic conformity. And we're not really yet to evidence-based conformal therapy. So we hope to have it by 2010 and 2000, maybe 2020. Let's keep our hope alive. Again, we've talked about how we've improved in our delivery, but we're still treating tumor volumes as if this whole tumor has the same risk of failure, which isn't true. This tumor volume has some areas that are at low risk and some areas that are at higher risk. And if we could identify those spatially with imaging, we could put more dose here and shave dose here, sparing all that normal tissue. We could deliver better therapy with better information inputs. So one of the reasons we've been interested in MRI is you can image all of these different aspects of the microenvironment. So what's happening with the extracellular matrix or blood vessels, the cancer-associated fibroblast just means the normal tissue that's integrated within the tumor, and then of course the immune milieu. So that we can move to something where we can really tailor our treatments, so where the risk is, our radiation is, and where the risk is not, we don't put dose. We know that tumors don't fail all the same, but yet we treat tumors to a homogeneous dose. If we could identify that there are these subpopulations of tumor cells that are more aggressive and more treatment resistant, we could actually pinpoint those and blast those. And if that population changed, we could change our treatments dynamically. That's really the dream. So MRI allows us to do that. We use PET and CT as well. They give us additional information that's useful for treatment planning, but I'm not going to talk about those. I'm not going to belabor those today. With MRI, our new focus is the fact that we can not only see the tumors better in terms of the anatomy, but we also have the capacity to get functional and spatial information. I'm not going to get into this because you guys aren't biologists, but by and large, there's a lot of information that with one MRI acquisition we can gain about where the cells are in terms of their oxygen level, where the cells are in terms of their number, how much the blood flow is that's going through these. So to use this as an analogy, imagine if you just had the patient's anatomy, a standard CT or MRI scan. You have the outlines of a tumor or an organ. This is like looking at a map of the United States. You have an outline of something, and you can tell this is binary. This is a tumor, this is not a tumor. This is a kidney, not a kidney. But what if you had information about the relative topology? In this case, you might think of this as the relative density of cells within a region. And you could say, okay, there's actually higher cell density in this part of the tumor than in this part. What if you had information about the activity? So you knew where the cells were dividing, where they were active. That would actually look different than just where the mass of cells is. So this is kind of equivalent to looking at a map of the night sky, a surrogate for activity. What if you had information about the tumor microenvironment? So the regional, this is like subregions of the environment. Okay, these are topological maps. What if you had information about the relative rainfall? This might be analogous to blood flow. If you start putting all of these layers of information together, you actually get a very complete map. The problem is, what do you do with that information complexity? What is the information that's meaningful? What is the information that's useful? If you're trying to target one component of that process, how do you make that optimal? So this is what we're trying to do with advanced imaging. We're trying to get information from metabolic imaging, information about blood flow, information about cell density, spatially aligned in a way that's effective, and then we can say where the phenomenon is occurring and what's happening to it in a way that we can modify it effectively. We can do this in a lot of tumor types. Now I'm going to talk about head and neck because that's what I do, but you can do the same thing in prostate, where you take all of these different imaging information sets and then superimpose them. You can do it in breast, you can really do it everywhere. But head and neck is where I do most of my work. So put this as an example, one of the things that our group really spends a lot of time working in is something called dynamic contrast-enhanced MRI, which sounds really fancy, and it's actually very kind of ready for prime time. Basically what happens is we take a dynamic image, so we're constantly acquiring an MRI, and while we do that, we inject the patient with a contrast agent. As the contrast agent flows into the blood vessels, you can see the intensity changes, and we can watch that contrast flow in and wash out. And if you map that flow in and out of each little pixel of tumor over time, you can create a dynamic map that looks like this. So you can say, here's areas where there's high blood flow, here's areas where there's low blood flow. But you can also get information like, are there areas where the blood vessels are disorganized? They're not normal. Are there areas where the blood vessels are leaky? And what we've been able to show is, along with some colleagues from Britain, is that you can identify the areas where there is poor blood flow and low oxygen to the cancer cells. And this is important because it's these low oxygen cancer cells that are resistant to radiation therapy. So we can identify not just where's the tumor, but also where in the tumor are the cells that are most likely to survive radiation treatment. Because then we can potentially either increase the dose or give chemotherapy or use surgery to overcome that therapeutic resistance. We are able to track this over the course of therapy. So these things change over time. So here's the tumor at the beginning of treatment. You can see that this is how dense the blood vessels are at the beginning of treatment. By the middle of treatment, the blood vessel density has really dropped. So it's also important to realize that these data sets aren't static. Where you are on day 0 at diagnosis and where you are mid-treatment and where you are at follow-up have to be integrated. But it's important they also have to be integrated spatially. So you have to know, is this spot here the same as that spot there, which is non-trivial. We also do a lot of research in an area called diffusion-weighted imaging, which very simply uses MRI to determine how much water is moving in each little voxel, in each volume of tissue, and then represents that with an intensity map. By doing that, you can say, okay, here's areas where water is moving freely because there's not a lot of cells. But in areas where there's very dense cells, the water can't move because it's restricted by interactions with cellular membranes and proteins and all the stuff that's inside a cell, right? So we look at this restrictive mobility water and we can say that's an area where there's high cellular density. We can take that information, and we've done studies that have mapped that to pathologic information, pathologic data, that show that that's where these resistant cells lie, interacting with not only tumor, but also with the normal tissue that they're kind of integrated with. So bad-acting tumors, in fact, aren't all a big blob of tumor. They're tumor that has encroached and snuck its little tentacles into the normal tissue and made a home, and made a microenvironment that's very receptive to a tumor camping out and growing there. And in fact, those are the ones that do badly, which is a kind of interesting realization when you think about it. We can then also use this to track changes over time. This is a way of looking at blood flow without giving contrast. But in order to do this, we've had to do a lot of technical innovation. So you've got to immobilize the patient in a same mask position for treatment that you use for the MRI acquisition. And then you've got to line that up again and again and again for each of these acquisitions so that you have spatial uniformity. Because if you think that something's happening here, but in fact you're 2 centimeters off, you're not able to target the right area effectively. Again, managing this information over time is not trivial. So again, we have a lot of data sets that are matching us. The good news is we feel like a lot of these newer imaging techniques are really effective. So one of the things that we've been able to show is that with these newer imaging methodologies, we can actually predict which patients are going to respond to therapy. We can identify using these techniques that there are some patients who by the middle of treatment won't have any visible disease. So even before we're done with treatment, these patients have responded substantively. These are really good responders. But we can also identify patients who aren't good responders. So maybe we should escalate their therapy, or maybe we should treat those remnants of disease that are there. Our goal is to develop a system where, again, we can take this anatomic information and this functional information in a way to say, this is the area that's at standard risk, and these are the areas that are at higher risk. So we can potentially modify their treatment. Now, what about the rest of the head and neck? Well, in the last few minutes, I'm going to talk broadly about some of the stuff that we do where, this is a real map. Our maps don't always reflect reality. So as radiation oncologists, it's like the map of Texas in the mind of a Texan, which is really more like this. We think about curing tumor all the time. But this map doesn't reflect the relative importance. Normal tissue is really important. So we also have to be constantly thinking about not just what's happening with the tumor, but also what's happening with the information about the normal tissue. So again, MRI provides us some useful information because we can see normal tissue damage. So this is areas of the head and neck that were radiated, and you can see this scarring and fibrosis that occurs years later in the normal muscles. And that actually is something that our group has used and related to radiation dose. Those parotid glands, those spit glands, which are so sensitive to radiation, even during the middle of radiation, we can relate the dose and the radiation damage in terms of blood vessel damage. So we're using these techniques all the time. Again, by doing this serially over the course of treatment, we can follow what's happening with these individual glands and potentially modify their treatments on the fly. We're actually funded, I'm funded with Stephen Lai, who's a colleague of mine, because we're doing some pretty interesting work where we're looking at radiation injury to bone. So bone that's in the radiation field, we've always kind of considered just something that was a necessary evil to radiating tumors in the mouth. But the problem is these patients can have long-term crippling bone damage. So our hope is if we can image these patients and before they have anatomic bone injury, we can see these blood vessel changes. Maybe we can intervene with things like drugs or hyperbaric oxygen and prevent them from ever having these really bad side effects. This involves, though, going through that whole process we talked about before where you're segmenting the images, you're registering them one to another, you're taking the information from the dose grid and you're generating usable models for what's happening. And again, by doing these techniques, we can then identify patient populations who have either stable changes or transient changes, but then we can also identify the patients who are at really high risk of radiation injury. This is non-trivial. This requires a tight collaboration with our biostatistician colleagues, our imaging informatician folks, the folks who do DICOM coding, our medical physicists. It's really a team effort. So if we're looking at these changes over time, again, sometimes the map may look one way, like in one election in 2004, but the map alters. Things are not static. What's happening with the patient, what's happening inside the patient is not always the same. So when we think about spatial localization on a map, the same is true for where you put the radiation dose. So if you radiate a parotid gland in a mouse, If you radiate just the front part of the parotid, it acts different than if you radiate just the back part of the parotid. So again, if we can track these injuries to normal tissues in real time, we can identify subregions of normal tissue that might be more radiation sensitive that we're not even aware of today. So we've looked at this in things like muscles of swallowing and the parotid glands. We've shown that if you give radiation doses that we used to consider safe to muscles in the back of the throat, patients will develop swallowing dysfunction. But even before that, you can see imaging changes that are a harbinger of bad outcomes. And we can build then these muscle damage models that, again, we feed iteratively into our optimization systems. By doing this, we can get better, every year we get better and better and better plans. So we're reducing the side effect load as we go. We also have the capacity, and I won't get too much into it, to image motion. So things that move, like muscles involved in swallowing or the lung or kidneys during treatment, we also incorporate these motion techniques. So we worry about patients swallowing during therapy, and we've evaluated swallowing with these techniques so that we can monitor in real time where the patient is, but also look at their swallowing function and integrate it with the radiation dose. If you know, for example, how much something is moving, and you know the relative mass of something they're swallowing, you can actually get force vector diagrams that show how well they're pushing food down their throat. So this tells us not only where the thing is in space, but also tells us after radiation, can the patient still swallow effectively, or have we damaged those muscles and normal tissues to a degree that we've actually harmed the patient? We track these anatomic changes over time. We track the functional changes over time so that you're iteratively getting as big an information set as you need. Now the problem is, to be honest, with all this flow of data, we really haven't had information systems that have been built to handle this. Our information architecture was built as we transitioned from those very simplistic processes we talked about at the beginning, and we kind of brought it together. So there's still a huge unmet need as we bring together not only all of this imaging data, but also patient-reported side effects, information from the EMR, and information from the radiation oncology electronic medical record system. And we haven't even talked about things like advanced biomarkers and genomics, which are, again, big data problems. So integrating these massive repositories of data in ways that become clinically meaningful is a real hit or miss affair, and one that we're really working on functionally. So for example, it took us 2 years to get this workflow for just mapping dose and response, which is a minor component of these bigger processes. That's just the first steps so that we can then map those image files and the dose data to the individual structures so that we can come up with usable models of all these tissues so that we can actually get a usable model of side effects. So this is a study we did where we looked at dose to a ton of different structures in the head and neck, and we found out that surprisingly, the real driver of these side effects was not radiation dose to the structures in all patients, but it was in elderly patients. That individual patient factors like age were as big a driver as the physical dose delivery. So when you get too myopic and when you get too focused on just the radiation component, we always have to be bringing in clinical data. We always have to be bringing in extra information in ways that we can use these in ways that are useful to model. This becomes especially important as we also move towards technology development. So our next step at our facility is we have a device that simultaneously gets an MRI and delivers radiation treatment. So it's an MRI and a linear accelerator, so you can image the patient while you treat. So as part of a cooperative group with the University of Utrecht and Electa Medical Systems, we've got this installed and are doing quality assurance practices, and we'll begin clinical trials on this later this year. This presents a great opportunity, but also a huge challenge, because now we have all this extra information. So up until recently, we were only really using CT information with high frequency. Now we're using anatomical MRIs so we can see the tumor better, different kinds of MRIs so we can get better dose calculations, but all of these functional data sets, and we're acquiring them over time. So we're having this exponential increase in the amount of information that we're having to handle, and then trying to reduce that into something that can be used for clinical decision making. So a lot of these processes just don't exist yet. So this is a grant we put together where this information about how to use these functional imaging maps and how to track what's happening over time and how to integrate it with the software, those are new things. Those are new areas of development. These data structures were actually part of our technology plan. And again, these are complex. This is a 5 and 10 year workflow. So in order to do that, I was fortunate enough to have Dean as one of my K-12 Calabrese Career Development Award mentors. So for 2 years, I worked with Dean and John Hazel in imaging science, folks from MD Anderson, Jayshree Kalbathy-Kramer from MGH, who's an imaging informatician, to actually develop these infrastructures for our clinical trial systems. So at the end of this, this process, I was able to get my clinical informatics certification, but also I was able to get this appointments to a host of committees that have been able to help us leverage this data. The other thing that we've happened is we have a series of trials that are utilizing this data infrastructure for iterative functional imaging in ways that we can start to correlate that with EMR and patient outcome data in an automated way. So instead of having to do it iteratively in a supervised way, it becomes an unsupervised loop. As part of that also, we've developed some precision medicine-oriented initiatives at MD Anderson, and I'm funded on an NSF grant with researchers from the University of Chicago, University of Minnesota, and University of Iowa, where we're looking at Bayesian machine learning systems for integrating multi-set clinical data with missing data imputation so that we can start to look at grouped data at large scale to make individual patient decisions. So what I'll say is predicting the future is not easy. We all know that we want disparate streams of information correlated. So everybody knew, even back in the 60s and 70s, that you want to talk to mom and look at her at the same time. But where that actually developed is actually a far cry. And no one in 1970 would have suspected that you walk around and talk to mom on your phone while you're on the bus. But what we believe is that richer data sets that actually identify what's happening dynamically with the patient in real time are always going to be better. And so informatics is the future of radiation oncology. Thank you. I'll take questions. Questions, comments? Yeah.
So one of the areas I work in is patient safety, particularly around device usability.
Yep.
And I'm sure you're aware of the FAIR Act.
Yes. Yeah. Yeah.
Where, despite the fact that, in my opinion, and I think the opinion of a lot of us who work in this area, it was the machine's fault.
Yes.
It was the humans who got fired.
Yeah. Hard to fire the machines.
Yeah. Well, no, they should have gone back to the designer and fired the designer and sued the company. So my question is, where are things at now? This is even more complex. You mentioned one dosing issue.
Yes.
How is that being looked at? I don't think the FDA is going to handle it.
No. So,
complex.
yeah. So it's interesting because for us, FDA approval is of the dose calculation and delivery system, but the UI UX is almost entirely unmonitored. So if you look at so to put this in perspective, part of my PhD thesis was actually on looking at human-computer interface modification and performance improvements. And we've shown that fairly simple improvements in image display change the decision-making process. But even so, I mean, these are such complex processes. The reality is they're so high complexity that eventually they get almost black box. So they have to have high levels of QA, QI. Certain components of those, the ones that are regulated, are really, really hammered. So dose delivery, because of the THERAC, and there's been some other incidents, are heavily, heavily regulated and QI'd. But the actual inputs are often not. So you can deliver a terrible plan, and if you deliver it consistently, you're fine, as long as the inputs are never checked. So we expend an enormous amount of time, manpower on that, but it's a huge unmet need because you have to have folks who have expertise in each of the component processes, and it takes an awareness of these processes that is not intuitive. Our processes don't look like, it's not like medication error reporting, right? It's not click down menus. It's segmentation, and it's really tricky. Even more tricky is when we do these segmentations, I'll often have plans that have 7 or 8 different dose levels. So it's not just the dose, it's I want this dose here, I want this dose here, I want a lower dose here, I want a lower dose there. And identifying whether you've even made an error actually gets hard at certain points.
So is anyone working on imaging informatics approaches to automating these?
Yes. Yeah, there's actually, so there's an organization, McKay. Are you guys familiar with McKay? So McKay is the medical imaging, MICCAI. But there is a huge group that works very, very closely on imaging, segmentation, image registration. So there's a great wealth in that domain space. The problem is those often are done by academic guys, and all of our machines are done by vendors. And so you have these guys who come up with awesome solutions, and they get great NIH funding, and it's never commercialized. And so our commercial solutions are often really suboptimal. So an academic institution like Anderson, that's not a big deal because we can set a PhD and say, okay, we want you to integrate this in a custom workflow that uses this open source, open access MATLAB script and then pulls it back into our QI chain. But if you're a regular radiation oncologist, you just kind of have to have whatever the vendor gives you, which sucks. Yeah.
One more question?
Yep.
So you talked a lot about essentially integrating more and more and more information into it. How far do you think we are away from the point where the better use is not how much data, when we grab it?
Yeah.
Because there is a cost in doing more imaging and everything, either through load to the patient or just sheer.
Yeah, exactly. So this is actually something that is a very important point. Just because you can acquire the information doesn't mean it's meaningful. It doesn't mean it's useful. The problem is because we're so new at acquiring it, we haven't. You have to be able to. For example, we've got this MRI Linac device. This will allow us to get an MRI every day of treatment and potentially redo the patient's plan every day. We don't really think we need to redo the patient's plan every day, right? But on the other hand, because we've never had that information stream, we don't really know how frequently we are going to need to. Do we need to do it once a week? Do we need to do it every 3 weeks? Do we wait for some kind of trigger? Is there some indicator? We don't really know. So the problem is right now for many of these technologies, we're so new in our experience levels that we're still just acquiring the relevant priors before we can actually optimize the processes. But it's true. I think in the old days, what limited us was computational speed. I could only redo the patient's plan based on how fast I could do Monte Carlo simulations. Now I can do Monte Carlo simulations on my GPU faster than I could on a huge array that I started on when I was an intern. So now computational speed is not my choke point. So now it becomes patient load or resource allocation but actually the real value is you really want to get down to clinical value. Like you don't want to do things just to do them. You want to, because every time you redo the plan, you introduce a possibility for error. So instead of increasing your complexity unnecessarily, every time you increase the complexity, there has to be some potential patient gain that's demonstrable. And once that becomes diminishing return, well, then you should truncate the process. But it's a great question. We're not, I don't think we're there yet because I think we're still on this information acquisition curve.
All right.
Yep. Thank you all.
So we don't have anyone to do anything.
Nobody.
I had this question. I hired a guy. I was a Kentucky student.
Yeah.
Started a division. I hired an imaging informatics guy in Yankee, Florida, who does this sort of
Yep.
thing.
Well, they're rare as tin's teeth.
And
they're.
Now, I will say, he has software in Siemens ultrasound machines because he would intern in summers
Yep.
as a student. And so this stuff is implemented in commercial.
Well, and it's so weird. I'll be honest. Anderson doesn't have